Hello. I'm sorry. Okay.
Saad, carry on.
Yeah. So I'm sorry. I think the Zoom link that went down. So I welcome you all to yet another session from the Residence Corners module. These sessions are arranged by Department of Neurosurgery at Liaquat National Hospital. Today we do not have one of our in-house presenter, but we have somebody from Dominican Republican, who's actually a neurosurgery resident in Russia. Our presenter today is Dr. Manuel Encarnacian Ramirez. He studied medicine at University of San Domenico. He has masters in business administration, medical business administration, and in clinical research. He's currently fourth year neurosurgery resident in Russia. It is good to have you, Dr. Manuel. Our expert panelist today is Dr. Azam Ahmed. Dr. Ahmed is Associate Professor of Neurosurgery and Radiology at the University of Wisconsin. He is Medical Director for the Brain Tumor Program and also Director for the Multidisciplinary Pituitary Clinic. His interests are skull-based, cerebrovascular, both open and endovascular. He has received multiple awards, including the Residence Teachers Award twice. He also looks after the Brain Tumor Program. Thank you, Dr. Azam, for joining us. The topic of our presentation today is surgical approaches and a bit of anatomy to the fourth ventricle. And I will request Dr. Manuel to please share his screen.
Yes, thank you to everybody. I'm very glad to be your guest, Professor Sharif. Thank you very much for allowing me to be part of your guest. It's an honor from me. I'm gonna share my screen with all of you.
Dr. Manuel, are you there with us? Your screen has paused, actually.
You can see my screen, right? Can I start?
No, we cannot see your screen. We can see your screen, but the presentation isn't up yet.
Yes, it is. I didn't start yet. I just want to know if you can see my screen and I'm gonna start to share.
Yes, we can see your screen. You can start.
Oh, my bad, sorry. This is too modern for me. I am doing from. I'm so sorry. Okay, so we're going to start talking about the fourth ventricle and the surgical anatomy of the fourth ventricle. Thank you so much for the introduction of myself. My name is Manuel Encarnacian Ramirez. I am resident of neurosurgery in Moscow, Russia, and I am the coordinator of anatomy UNESCO in the Russian Federation. Once again, thank you so much for the invitation. So first, we need to know what is the fourth ventricle. As we know in the embryology, we're going to have different vesicles, different cavity in the development of the neural tube. One of these one here in the rhombencephalon is going to be the fourth ventricle. The fourth ventricles connect rotally through the aqueduct of Sylvium with the third ventricle. And inferiorly, caudally, is going to connect with the foramen of Magendie to the cisterna magna, foramen of Luschka to the cerebral ponting angles. A trick I always use when I was a medical student is Majendi middle twice. Okay. Okay. So we're gonna see now a digital cut of the fourth ventricle. Also, we're gonna have here the bones. Ventricle in the middle part is gonna share a wall. It's gonna share the floor with the bones and with the medulla oblongata. We're gonna see more ahead in the shape of the fourth ventricle. So, you know, to understand from the simple to the complex, the fourth ventricle is gonna have a floor here, but also gonna have here, and borders, 4 borders, okay? And we're gonna see what is gonna be the borders and the angles. So we are watching this schematic drawing of the 4 ventricles, and we're gonna see here the borders of the 4 ventricles. The border of the 4 ventricles is gonna be the peduncles, cerebral peduncles. And we're gonna see we're gonna have 3 of them, 2 superior, 2 inferior, and 2 middle here, okay? And we're gonna have the roof. To start seeing the roof, we're gonna have here the middle cerebral peduncle, okay? We're gonna have here the superior cerebral peduncle, and here, this one here is the middle cerebral peduncle, okay? The bones is the biggest one of all the peduncles. Remember, this is a sagittal cut. This peduncle is gonna find the tracts, pontocerebral tracts, and also the serotonergic tracts, okay? And we see here, we're gonna have here the superior cerebral peduncle. This is here with the cerebellum. This peduncle is gonna have the ventral spinocerebral tracts, trigeminal tracts, cerebellum cerulo tracts, and also the cerebellum tectus tracts. These tracts, remember, these tracts go through the cerebellum to the cerebellum outside, or from the brain, from the telencephalo, or of the brainstem to the cerebellum, okay? And then
I'm sorry, Dr. Manuel, your voice is breaking between.
Inferior cerebral form body.
Dr. Manuel, your voice is breaking in between. Can you check your Wi-Fi connection?
Okay.
I mean,
Yes. Okay, do you hear me now better?
yes, it's better now. It's better now.
Okay. Okay. Sorry for that. So here we have the inferior cerebral peduncle, or also they call the horestiform body. This peduncle is gonna connect the cerebellum to the medulla oblongata down here. It's have the large amount of the tracts. We can have the dorsal spinocerebellar tracts, cuneocerebellar tracts, also the olivocerebellar tracts, reticulocerebellar tracts, vestibulocerebellar tracts, and also the trigeminocerebellar tracts. Okay, as you can see, this tracts is going to have both ways, ascending and descending way of the tracts. And we're going to have here, pay attention and don't misunderstood with the superior cerebellar peduncle. This is the superior medullary velum. As you can see here, this is a fit prepared body, but usually it's a thin transparent lamina of white matter. Okay, and it's gonna be between both of the peduncle. You're gonna see here. You can see here superior peduncle here, and you're gonna find here between both of them. So
It's gonna form together with the superior cerebral peduncle, the roof, the superior part of the roof of the four ventricles, and it's narrow above where it's passed between the facial colliculum. Remember, here we're gonna have the facial collicle here, okay, and here we're gonna see here the trochlear nerve going out here, okay. So this part is the smallest one, the thinner one is gonna be called the frenulum belli. And here we're gonna find also the inferior medullary velum. It is also a thin layer of the white substance and is prolonged in the center of the cerebellum. And if we go more down and inferior, and we cannot misunderstood, okay? This is a choroid plexus, and we're gonna see what is going there, okay? Like the support of the choroid plexus, okay? This choroid plexus is, as we know, is a very high vascularized epithelial tissues. It's gonna produce, as we know, all the CSF in the four ventricles. The artery supply of this choroid plexus originate in multiple arteries. Gonna be from the pica and also from the ica. And there we're gonna find, remember, the M Magendie. This is the foramen of Magendie. And if we go more there, we're gonna find this is the lateral recessus of the fourth ventricle, lateral recessus. And in the bottom there of the lateral recessus, we're gonna find lateral recessus foramen of Luschka. Exactly. Now we are watching a view from posterior to anterior, and we see lateral recessus, and then we're gonna find the foramen of Luschka, and down here we spoke foramen of Magendie. So as we spoke before, we find here superior cerebellar peduncle. It's cut here, but we see the middle cerebral peduncle and inferior cerebral peduncle. Again, when watching it now, an anterior view of the fourth ventricle, we dissect the pons and the medulla oblongata. As you can see here, all the choroid plexus here, all the choroid plexus of the fourth ventricle. You can see here from anterior to posterior the foramen of Luschka. Remember, this is the lateral recessus, foramen of Luschka. And again, you see all the choroid plexus, tela choroidea. We're gonna speak about that. Tela choroidea. Don't misunderstand the tela choroidea with the inferior medullary velum. Okay. Again, we cut here. We are watching it from, we cut anterior to posterior here, and also now we're watching from superior to inferior, and we see the choroid plexus, lateral recess, and from lateral recess, remember, we have foramen of Luschka. Again, we're watching this superior medullary velum, choroid plexus, remember lateral recess, Luschka, lateral recess, again, Luschka. Choroid plexus, this is the nodule, this is part, we're gonna, when we understand the basic anatomy of the fourth ventricle, we're gonna understand more easily the telomere approach. So, how we go through to the fourth ventricle? Before there was an approach, transvermian approach. This is vermis, and before the surgeons make this kind of approach through this organ, through this vermis, and the patient have a lot of problem. We're going to see more ahead. So now we use a more kindly approach, more gentle approach. And this is going to be the telomere approach. So now, again, we're watching, we move some structures. We remember what kind of structures are there. You see here, tonsils, uvula. It's like tonsils, uvula is like on the mouth, widely. because if we open the mouth, we're gonna have this. This is the uvula. Have the tonsils. We have the tongue. Okay. And now we're watching it from inferior to superior, and we see here telachoroidea, inferior cerebellar peduncle, and you see here telomeral junction here, and after you can see we move laterally and superiorly the tonsils. And there we have foramen of Magendie. Again, the telachoroidea, inferior. So here, this is the view we're gonna see it usually. We have here the tonsils or amygdala, also some author they call cerebellar tonsil or cerebellar amygdalas. We move, and then remember what we have in the bottom. It's like when we open the mouth, we're gonna have the uvula. And then we have the telachoroidea. As we spoke before, what's that? Telachoroidea. This is a region of pia mater, and is thick, is addressed to the underlying ependyma. It's give to the choroid plexus. It's like the rise of the choroid plexus in this fourth ventricle. The telachoroidea is very thin. It's very loose, very thin, loose connective of the pia mater overlying. Okay, it's very close to the ependyma, and is have a very rich blood supply. For that, we're gonna find the choroid plexus there. Okay, let's see. This is choroid plexus, but I'm gonna show you another picture when we can find the choroid plexus there. Yes, exactly. And we're gonna see here the choroid plexus. So again, amygdala. We move the amygdala here. Uvula. As you can see here, this is the inferior medullary velum. And here we have the telachoroidea. As I said before, we have this choroid plexus very easily, the choroid plexus. Remember, the choroid plexus, the function is the production of the CSF in the ventricles. So again, we have here the superior cerebellar peduncle. We have the lateral restes, and more there we have lush, okay? Here, this is the floor of the four ventricles, the floor of the four ventricles. And if we see in the top, we're gonna have the aqueduct of Sylvium. So I'm talking about the floor. To understand the floor, as we need to remember, now we know the roof, we have the velum superior and inferior. For that, you see the fourth ventricle is have like the shape of a 10. But what about the roof? Because if you see the roof, the roof of the floor, sorry, the floor of the fourth ventricle share two floors. One with the pons here, with the pons, and the other part with the medulla oblongata. So this is a rhomboid, as you can see. This is a rhomboid, and we're gonna find before the borders. We're gonna find the borders here with the superior cerebellar peduncle, middle cerebellar peduncle, inferior cerebellar peduncle. Okay, and we're gonna have some structures there. Facial colliculus. I'm gonna talk more next about it. The locus coeruleus. This part here is involved with the physiological response to stress and the panic. This is like it's part of the reticular activating system, the SARA. It's like a blue spot. It's green here, but usually it's a blue spot. And the principal function is to produce the noradrenaline here in the brain. So more down here, we're gonna have the area postrema. You see here the area postrema. area postrema is related with the vomit, the emetic, the vomit area. So again, we can see here, locus coeruleus in blue, area postrema, and we're gonna have more structures. We're gonna have more structures here. This is the view we're gonna see. Remember, superior cerebral peduncle, middle, inferior. You see here stria medullaris. Here, triangle hypoglossa. Inferior, we have vagal triangle. We have the orbes, area postrema. Here we have the we have the middle line here. Lateral to the more lateral, we're gonna have the abducens nucleus. Okay, and then we have the colliculus facialis, the facial colliculus. This is not one structure. It's composed of two structures. One is I'm gonna show you a very good cut about it. More inferior, we have the hypoglossal triangle, and more inferior to that, we're gonna find the vagal triangle. And if we go more down, remember, area postrema. So if we see this in this view, we're gonna find, as I say you before, this is the abducens nucleus, and then we have all these structures you can see very well here. This is the facial nerve. As you can see, the facial nerve surround this abducens nerve, and then it's called colliculus facialis. You can see here in the middle line, and here, this here, this is the middle longitudinal fasciculus. Here, this is the trigeminal mesencephalic tract. And if we go more down here, this is the central tegmental tract. So sometimes in patients when they have the hydrocephalus, we cannot find this like small bulb here, because it's like plain. This floor of the fourth ventricle is plain, but usually this is like our landmark, this colliculus facialis, because you can see this small bulb there. So radiologically, you can see here very easy. You can see the aqueduct, mesencephalic aqueduct, going to the fourth ventricle here, this like 10 shape, and inferiorly to the Magendie aqueduct, laterally, Luschka. Again, you can see here the foramen of Luschka here, and you can see here the posterior recess. Here you can see the Magendie foramen, and you can see the orbits. Again, Magendie. You can see here from the Magendie to the cisterna magna, and from the Luschka to the cerebral CP angle, cerebral peduncle angle. Again, you can see here the superior medullary velum here, and the foramen of Magendie here, and superior medullary velum here. So, in which way is going to be the best way to go to the fourth ventricle masses, like any tumor? So these tumors have traditionally been removed via the transvermian approach, which can result in a potential disequilibrium and mutism in the patient. The telomeral approach is an excellent alternative to the widely exposed fourth ventricle tumors, without transgending, without make violation of the cerebral dermis. So for that, we have the telomeral approach. As its name say, we go through the telachoroidea. So this approach access to the fourth ventricle in very gentle way. Aside to the way we used to go there is mobilizing the cerebral tonsils laterally, as you can see here. Move laterally. We identify the telachoroidea and the inferior medullary velum. So remember, this form the lower half of the roof of the fourth ventricle. and you can see the arachnoid opening. You open the arachnoid, and you can see in this yellow line, we open there, and we can have a full access to the fourth ventricle without violation of the cerebral dermis. So, in which way we want to do it, step by step? We can have different position in the patient. One position is the Concorde position. If you remember this very pretty airplane called Concorde, it's like this. The patient we place in the prone Concorde position with the head and the main field pin, the head holder, and we start a midline craniocervical skin incision. You can see here. Usually, we can use the monitoring of the patient to monitor the lower cranial nerve. Okay. You can see again the midline incision, and we can drill we can recess the posterior arc of the atlas, or we can make also the laminectomy in the axis. So we're gonna use the neuromonitoring here. And after we remove we make the bullhorn, we remove the bone, then we open the dura mater in the G shape, you can see here in this shape fashion, and then the dural leaf splits, we track it, we move out of the operation field. You can see here, it's like a G. You see, and we remove all this here. Again, you can see the supercipital approach. We remove all this here. We can remove C1 and the laminectomy in C2 to have a better exposition of the patient, okay? So we can remove the posterior arc of the atlas and laminectomy in the C2. Then we remove the atlanto-occipital membrane. And then this is our view. Remove dura. We open the dura. And after we open the dura, then we're gonna have here the cisterna magna. We open cisterna magna. As you can see here, the cisterna opening. And then, as you can see here, it's like when the patient open the mouth, we're gonna see these guys saying hi to us. This is the tonsils. This is the tonsil. The tonsil is gonna say hi to us. Very careful. And then we move. Something we need to remember is the trajectory of the pica. The pica is gonna be all over around in our approach. This is the vessel we need to be careful of all the vessels. But with the pica, we need to be very careful because it's gonna be in almost all the stage of this approach. And you're gonna find it very very attached to the tonsils. Again, as you can see here, very gentle retraction. We open the telacoroidea. And then we are there in the whole fourth ventricle. You can see here, you remember we spoke about this like little bulb there. This is folliculus facialis. Folliculus facialis. If the patient have like hydrocephalia, it's gonna be sharp, it's gonna be smooth there. Again, we need to check our roof. We need to, in our mind, we need to have all the part of the floor of the fourth ventricle. Again, we have facial colliculus. As we see here, facial colliculus here. We are watching from inferior to superior. This is the Telomere approach. We see stria medullaris, remember, hypoglossal triangle. the vagal triangle, orbits, area postrema, locus cereus. Okay. So that's all with the Telomere approach and the anatomy of the fourth ventricle, and make a very brief and simple explanation. Thank you so much.
Thank you, Dr. Manuel, for your presentation. Now, I would like to request Dr. Azam Ahmed for his expert opinion and maybe share some of his cases as well.
Yeah, so I guess I would say this is a very, very nice presentation and overview of the fourth ventricular anatomy and approaches to the fourth ventricle. What I would say, a couple of things. Number one would be that, if you go back to the slides that you had of the fourth ventricle for a second, if you don't mind.
Yes, of course.
The fourth ventricle, yeah. So one of the key things that I think it takes some experience to learn is what are safe entry zones to the brainstem and what is not safe. And when we talk about safe, it's not just that, can you get through the operation or not? It's what is the morbidity that's caused to the patient. And what I'll tell you is that the floor of the fourth ventricle is very unforgiving. What I mean by that is that if we look at this, what we call the calamus scriptorius, which is right in the midline here, the hypoglossal trigone and the vagal trigone, up to involving the facial colliculi. All of these areas are very unforgiving, and these are where all the motor nuclei live along the midline. Even with very expert neurophysiologic monitoring, you can map these out very well and find the midline extremely precisely. But working between these very important tracks often results in significant issues for the patient, swallowing problems from which they have great difficulty in recovering from, difficulties with maintaining or handling their secretion. So this becomes a lifetime problem for that patient. So as far as, we talk about safe entry zones to the brainstem, the midline of the fourth ventricle is to be avoided. What is possible, however, is if you go lateral to the sulcus limitans. So the sulcus limitans is what separates the facial colliculus from the lateral to the lateral portion of the floor of the fourth ventricle, the rhomboid fossa. That area lateral to the red lines there is the vestibular area. And the vestibular area is much, much more forgiving. So when considering approaches to the brainstem, the midline should be avoided at all cost, and only method of entering the brainstem lateral to the sulcus limitans should be considered. Now, if you need to get to the brainstem, and even if the tumor seems like it's covered by the thinnest layer of brain, I avoid the midline of the fourth ventricle still in that situation, and would much rather prefer going through the middle cerebellar peduncle and taking a much more lateral to medial trajectory. That is far better tolerated than going in the midline of the fourth ventricle. So I hope that that point is well heard by all of the trainees. Now, that does not mean that you cannot approach tumors in the fourth ventricle. It really comes down to if they're exophytic and filling the fourth ventricle, or are they involving the brainstem to a significant degree. For instance, ependymomas. So ependymomas often, they end up growing exophytically into the fourth ventricle, but a very small portion of the tumors actually attach to the floor of the fourth ventricle. And at that point, depending on where that ependymoma is located, oftentimes it is adherent lateral to the sulcus limitans. And in those areas, a little bit of venturing into the brainstem is possible in situations where that where the ependymoma is adherent in that location. Otherwise, if it's adherent along the midline of the fourth ventricle, the patient would fare far better to trim off the ependymoma at that level and potentially treat the patient with radiation in the near future, as opposed to causing a definite problem by venturing into the brainstem there. Other pathologies that are often encountered in this location would be subependymomas, would be another one. Pediatric, all of the pediatric midline tumors. And again, it comes down to how many of those are dorsally exophytic. So the other point I would really like to make here is that it's so important that the patient be positioned properly. The pathology determines the corridor. So if there's a large fourth ventricular tumor, the tumor has created the surgical approach corridor for you, and that's very straightforward and relatively easy, and you can see very nicely up to the aqueduct without much difficulty. But the smaller the tumor is, the less that corridor is created, and the more important positioning becomes. Because if you want a view that takes you beyond the middle of the fourth ventricle, beyond or above the lateral recess, that is very difficult to see unless the tumor has created the corridor for you, or you've done a very good job at positioning the patient very well. At our institution, oftentimes anesthesiologists will say, well, the patient's head is too flexed or tubal kink, et cetera, et cetera. And these are all important considerations, but one of the things that I like to use for these when I really flex that patient in the Concord position is a reinforced endotracheal tube. This avoids issues. Oftentimes halfway through the case, a few hours in, the anesthesiologist say, well, having trouble ventilating the patient. And in these situations, at that point, it becomes a real problem. You cannot proceed with the operation. But a reinforced endotracheal tube can really help with preventing the tube from kinking as the patient's body heat softens that endotracheal tube and causes problems. With the reinforced endotracheal tube, you can really put the chin all the way on the chest and not have to worry about the tube kinking or ventilating the patient. And I'm sorry I don't have more of my cases queued up here, but one of the other really nice approaches to this area is a paratonsillar approach. So instead of going right in the midline, you can go lateral to the tonsil. And that's a very nice way of approaching tumors that are primarily involving the roof of the fourth ventricle, where you'll have to only traverse a small portion of the cerebellum in order to approach that. So if you look up that paratonsillar approach, I think it would be a nice thing to add to your skill set. The last point I'll make is that, oftentimes the problem with approaching these fourth ventricular tumors is the retraction that we apply to the brain and to the surrounding structures. The way that we limit that retraction is by doing more extensile exposure. You really can take your exposure of your telovelar tonsillar approach all the way out from Magendie all the way to Luschka if you need to. The inferior cerebellar peduncles tend to be quite forgiving. And so if you have to, you can take those with very little deficit. The patient will have some issues with balance. Those tend to improve very nicely over the course of a couple of weeks to a few months. And that really allows you to really elevate the cerebellum and get a very nice panoramic view into the fourth ventricle. Oftentimes, this is limited because of the skin incision. When the patient is obese or is very muscular, the thickness that you're looking through with the muscular and the skin opening tends to be a very, very narrow corridor. So by extending the incision and widening that corridor, it will allow you to make a little bit of a larger craniotomy, which will help you with this lateral approach and making it more extensile for the telovelar tonsillar approach. Sorry, and I said that I said was the last thing, but the final thing, honestly, would be that the pica is of critical importance in this approach. If ever you're lost, the pica can help reorient you very, very nicely. And the course of the pica, while it's a little bit variable, the key segments are not variable and are always there as they should be in the same appropriate locations. And so that can really help you along with the dissection when the pathology has perturbed the normal anatomy. So with that, I would say, very nice job to Dr. Ramirez for his very nice presentation.
Thank you.
Thank you
so much, Professor.
Thank you, Dr.
I want to, it's very interesting. I never hear about this paratonsillar approach. You know, in my level as a resident, abstract is too hard for us because I was reading about some safe areas in this brainstem approach, suprafacial, infrafacial, the safe enter zone, but it's hard. But I'm gonna be very glad if in the next time, if you're gonna be available, I can read about the paratonsillar approach, and I can explain, and you can at this time you can share your experience, make some corrections, and guide me. So I'm gonna be very honored.
Yeah, that would be really wonderful, and I think that I think there's a lot that's been published on safe entry zones to the brainstem, and essentially avoiding the midline is the key thing to know. If you avoid the midline, that's 90% of approaches to the brainstem. In the posterior approach, I should say, that if you avoid that midline, you'll do just fine. If you're lateral to sulcus limitans, whether you're suprafascial, infrafascial, it usually tends to be quite well tolerated.
Thank you, Dr. Azam and Dr. Manuel.
Thank you so much.
If the participants have any question from Dr. Azam, now's the time. So, Dr. Azam, have one question is that have you abandoned transfemoral completely, or you still do it?
Say it again. Have I abandoned what?
Transfemoral approach complete. Have you
transfemoral for endovascular?
Transvermeal, going to the vermis.
Oh, going through the vermis. Yes, absolutely. There is never going to the vermis is buying a morbidity that the patient often is unable to recover from. Now, it's different if it's a vermian tumor. Obviously, if it's a vermian tumor, it's involving the vermis, and that's what needs to happen. That's fine. But going just adjacent to the vermis, between the tonsil and the vermis, is a much better approach, and you can really develop that that sulcus very nicely and go adjacent to the vermis.
Thank you. If there's any question, we'll be happy to take it. Since we have no questions now, I thank you, Dr. Manuel and Dr. Azam, for your time. Next week, we'll be exploring the cerebrum, and we'll be doing the central core. We'll be doing white matter anatomy and tectography. I will welcome you all to join next week as well. I again thanks Dr. Azam and Dr. Manuel for taking out time for this session, and we'll see you all next week. Keep safe. Thank you.
Of course, thank you so much. Thank you, Professor, and thank you to Professor Sharif for the invitation. To Professor Ahmed, right?
Yep.
Yes, cool. We meet next time and talk about this paratonsillar approach, because I never hear about it. And
yeah, that would be great. Yeah,
I like to read something new. Help me to understand very well.
We can have a session for safe entry zones for brainstem surgery maybe in the weeks to come, and we'll have Dr. Manuel and Dr. Azam on board for that.
My pleasure.
Sounds great.
Thank you.
Thank you so much.
Thank you.